Hi, my name is April. I'm a registered nurse. I am considered a mom-baby nurse or a postpartum nurse. I am responsible for taking care of you and your baby after you deliver. This module is for vaginal birth and what to expect 1 to 2 hours after your baby comes out. The first thing I want to go over is skin to skin. Right away, your baby will be placed on your chest skin to skin. Note, wear something that either unbuttons on the front, have your gown opening at the front, have a robe on, something where your bare chest can be exposed very easily. It makes it just a lot easier for you. We have gowns we can provide also. The nurse will cover your baby's back with a warm blanket and put a hat on. The importance of skin to skin or for hormone levels. It helps produce oxytocin, which helps with bonding. It helps produce prolactin, which helps with your milk supply. And it helps give endorphins as well, okay? So it can help with stress and pain, either urine or your baby. This is called the golden hour. A lot of hospitals are implementing this. Check with your provider, meaning your OB, which is your obstetrician, your doctor, if your hospital practices this. If not, you can request for the golden hour. Okay, so if that's important to you, make sure your hospital is following that, and if not, request. All right, so the golden hour, basically in a really quick snapshot, is we leave the baby skin to skin on your chest for the first hour. We do all assessments, all tests, everything with the baby on your chest. A little bit of complications can arise. If this does happen, we will be taking your baby off your chest within that first hour, bringing him over to a warmer most likely, and doing more assessments and diagnostic tests there. That can be completely normal. I know you guys really want things to go according to your plan, and an excellent plan to have your baby skin to skin with the first hour. That doesn't always happen. So just know that if we decide to take your baby off your chest, it's in their best interest, okay? We're not doing it just to steal them off your chest, okay? Let's see. How to prepare. I want you guys to ask your doctor about skin to skin during your prenatal visits. I want you to add skin to skin to your birth plan when you show up at the hospital. Let them know about your birth plan, and that includes skin to skin. And let's see, I already told you to wear a loose hospital gown or an opening that makes it easy in the front. And ask the nurse to keep you updated if your baby does need help and they were going to remove you. So you can say, hey, if you're assessing my baby and you're thinking that maybe if the next set of vital signs or the next thing that you're going to look at is not good, just if you can prepare me a little bit to let me know that it's a possibility that, you know, you're not going to make it this first golden hour, that we might have to remove the baby from the chest. Just open communication. Just make sure that you're letting your nurse know to keep you informed, okay? That's really important. Okay, the next thing I'm going to move on to is delayed cord clamping and cutting of the cord. So this happens within the first 30 seconds all the way up to 3 minutes. We do this now, it's standard of care in most hospitals, I believe, but we do this now because research has shown that your baby does get more oxygen, that they have a better blood volume, that they build higher iron reserves, which helps with anemia. Anemia is low blood levels. And they say you can gain more stem cells and immune protection this way. Once the cord is clamped, it can be cut. Often your doctor will see if your husband or partner would like to do this. That's totally fine if agreed upon beforehand. Prepare your husband, let them know that, or your partner, let them know that there is no nerve endings in the cord. This will not hurt the baby. That they will be cutting above the clamp. Some complications that can arise from this is that there might be a reason why we can't wait to cut or clamp the cord, okay, and that the doctor might have to cut on its own. There are many reasons why this could happen. Issues with your placenta, issues with your baby. So this is initially what is wanted, but does not always happen. How to prepare. You're going to talk to your doctor before birth and your wishes for delayed cord clamping. You're going to ask how long they usually wait before cutting the cord. Like I said, minimum 30 seconds all the way up to 3 minutes. So ask your doctor, what generally do you do? Do you wait the full 3 minutes? If so, great. If not, why? So you can feel prepared. If your partner wants to cut the cord, let the team know before that time arrives, meaning the staff in the room. Let them know that that's something that you guys want to do. Practice or talk about what it's like to cut the cord. That could be fun. Remember, things can change. If your baby needs help, trust your team knows what to do best. Next topic, vaginal tearing and repair. This is very common. What you need to know, what can go wrong, and how to prepare. So the area between your vagina and your anus, there's some skin, and that's called your peritoneal area. That is the most common place you tear. You can also have something called a periurethral tear, which is the opening up your vaginal up to your urethra. You can also have labial tears. So a lot can go wrong down there. We consider a tear between, we call it first degree, second degree, third degree, and fourth degree tear. Fourth degree is the worst. It's a tear from the vaginal opening all the way to the anus. First degree is the most minor tear all the way up to the fourth degree. Usually the doctor doesn't say, oh, hey, you have a fourth degree tear, let me fix this. They're just letting you know that you did tear and they're suturing you. If you would like to know how far you tore, you can ask your nurse or ask the doctor. They can tell you. I'm also going to put a link up in this video where I tell you what a first degree, second, third, fourth degree tear is. So you can have a reference guide for that, okay? Complications. Harder recovery, more pain, more swelling. The sutures are dissolvable, just to let you know. A lot of time I can't even see them. Things are swollen down there. You can get a hematoma, which is a pooling of blood underneath the skin. You can have pain on urination just from the burning of the urine on the tear. Let's see. And just it takes slower to heal. You may be more likely to tear if this is your first baby, if you've had a very fast or very long labor, if your baby is big, which is usually we consider big over 8.5 pounds, and if your doctor ended up using tools to help get the baby out, such as forceps or a vacuum. All right. I'm going to tell you guys next about what the nurse will be doing while your baby is on your chest. Just a quick rundown. We will be doing something called APGAR scoring. We look at a series of different things, give it a number in the first minute of life, and then 5 minutes later we scored a number, and that will determine if your baby stays with you, if they need to go to the warmer for some further treatment, or they need to go to the NICU. So we will be doing all that. You don't need to worry about it. You can ask us what the scores are. All ask. Whatever we're doing, feel free to ask. We can tell you. We'll check the breathing. We'll check heart rate, the baby's color, temperature. We'll do a full head-to-toe assessment. We'll be looking at the skull, the eyes, the nose, the mouth, the chest, everything. We'll be looking at it all. How to prepare. Know that this checkup happens quickly after birth and most of the time while your baby's on your chest. Ask your care team to explain what they are doing if your baby is taken to the warmer. If your baby goes to the NICU, ask when you can visit or hold them. Trust your team is trained to help your baby stay safe and healthy. Uterine massage and bleeding monitoring. Right after you have your baby, your nurse will go check your belly. We will do this very often, probably in the first hour to 2 hours every 15 minutes. Once you're transferred to your postpartum floor, this will be once a shift. If everything is stable, if not, more. Okay, so just know we will be pressing down on your uterus for quite some time. Your uterus should feel like a firm ball in your lower belly. It should not feel squishy. If it is squishy, it can lead to bleeding. I will also be looking at your pad in your underwear to make sure when I am pushing how much blood is coming out, if there's any clots coming out. So we'll be assessing all that. I'll also be checking your vital signs, and we will estimate the total amount of blood loss that you are having with your birth. Okay? We keep track of that. We have numbers and parameters, what's considered a hemorrhage and what is not. I'm not going to go into detail, but we will be keeping track of every drop of blood you lose, and we will be monitoring for signs of bleeding. Things that can go wrong. If your uterus stays soft and boggy, you may have heavier bleeding and you may pass larger clots. You might develop a postpartum hemorrhage, which is considered serious blood loss if your uterus does not shrink right away. Us massaging your uterus helps it shrink and become firm. Uterine cramps can be strong and feel like bad period cramps. This is more common after each birth. This is your body doing what it needs to do. Uterine cramping is good. That means it's shrinking, the blood vessels are shrinking, your body is returning back to normal. Your uterus will start to shrink down where it's supposed to be and go back down to the proper area that it was prior to getting pregnant, okay? How to prepare. Expect your nurse to press on your belly often, and it can be uncomfortable, but it is very important and necessary. Let your nurse know if you feel dizzy, see large clots, or feel a gush of blood. I always tell my patients, please tell me if you feel a gush of blood. Anytime. I want to come check it. I don't care if you looked and you don't think it's bad. If you get a gush of blood, I want to know about it. So just let your nurses know. If you pass a clot when you're up to the bathroom, don't flush it. Let your nurse look at it, okay? We'll come in and be like, how's your bleeding? And people will be like, oh, it's good. And then I'll see your pad and I'm like, oh, well, that's not too good. So when in doubt, ask your nurse. Try to pee as soon as possible. This is really important. If you have a full bladder, it pushes your uterus off to the side and will not let it become firm. Full bladder right after delivery is not good. Empty your bladder, ladies. Get up and go to the bathroom. I don't care how tired you are. We will help you get up. We will put you in some sort of transfer machine. We will get you up to the bathroom even if you can't feel your legs. Peeing is very important. I cannot stress that enough. And then just know your cramping's normal. We will give you Tylenol, pain meds, all of that. That is completely normal. Okay, initial breastfeeding. So in that golden hour, that first hour, we are going to attempt to latch your baby. Oftentimes, they will already be showing signs that they're ready to eat. That includes lip smacking, like wandering of the head all over your chest, some irritability. A good feeding means that your baby has a deep latch, is actively sucking, and stays on for several minutes. An attempted feeding means your baby was put to the breast but may not latch or stay long. That's okay too, it's part of learning. The first milk you make is called colostrum. It's thick and yellow and full of nutrition. Your baby's tummy is tiny, so just a few drops are enough. So when your baby's first born, their stomach is the size of an almond. They only need 2 to 3 drops of colostrum in that first 24 hours every feeding. So every 3 hours, if they get 3 to 5 drops, that's considered enough in the first 24 hours, okay? I can't stress this enough. The biggest upsetting thing in a hospital for parents is breastfeeding. And I really think it is seeing it go in versus seeing it come out. When you can't physically see it go in, it's just like this extra stress, you know? You're like, oh my gosh, I just fed. The baby's crying. It must not be eating. No, some babies cry. even when they're not hungry. Okay, they're either crying because they have a wet diaper, or they're tired, or they just want to be, soothed at the breast. So it's a really big stressor, but trust me, you guys, if your baby is latching every 3 hours and getting a couple drops, you're golden. I like to tell my patients, attempt to breastfeed in the first 24 hours. Your newborn is so sleepy that they can go for the full 24 hours without eating if they had to, okay? They will, nothing severe is, we're monitoring these babies, okay? Trust me, trust us. We are not going to starve your baby, okay? Okay, how to prepare. Let them know if you want help with latching or if it feels uncomfortable. Watch your babies for signs of hunger like lip smacking, turning their head, or sucking on their hands. Keep your baby close to skin. It makes feeding easier. And then make sure you're asking questions. Every time you latch your baby, you can press your call light and we can help you. We are trained to do that. A lot of hospitals have specialized lactation registered nurses that can help you, but we are all sent and trained to help breastfeed, okay? I'm going to do a whole nother module on breastfeeding because that's a huge thing on itself. But just know, in that first 1 to 2 hours, you will be trying to latch your baby. Let's see. Newborn medications and checks. So right after your baby's born, you'll get some important care to help keep them healthy. Nurses call it eyes and thighs. This includes 2 shots in the thighs, or 2 shots. Includes 2 shots in the thighs and 1 medication in the eye. So eyes and thighs. Eyes is erythromycin ointment. This is put on after your baby comes out of the vaginal canal. They want to prevent any bacteria or anything that the baby is exposed to coming out of the birth canal, okay? Vitamin K is a shot that they give in the thigh. It helps blood clot. It prevents bleeding in the brain and body. Hepatitis B vaccine, it protects your baby from a serious liver disease. You are their parent. You have the right to give or refuse any medication. You have the right to say, erythromycin, can you tell me what that is and explain it to me? And what are the risk factors if I don't get it? We are all educated to tell you that stuff. You have to make your own personal decision. I will not say, I would get the thighs, but not the eyes, or, the eyes are okay, but not the thighs. You guys do your own research, please, and you decide what you want to do. But the standard of care is to offer erythromycin eye ointment, vitamin K injection in the thigh, and hepatitis B vaccine in the thigh. My hospital that I currently work at, we will have you sign a refusal form if you refuse the hepatitis B, and also if you refuse the vitamin K. And the ointment, I believe, you guys have to sign a refusal form, and then we scan it into the chart. Some parents don't know this is going to happen. It can be kind of shocking that your baby just came out and all of a sudden they're getting shots in their thigh. Just prepare yourself that that's going to happen. There could be a little swelling or redness at the injection site. That's normal. Rarely do babies have any reaction, but they can become fussy and have mild fevers. And then skipping any of these meds can put your baby at risk for infection or bleeding issues. How to prepare. Ask your nurse to explain each medication before your baby gets it. Let your provider know ahead of time if you have any questions or want to delay anything. Know these meds are strongly recommended by doctors to keep your baby safe, and hold your baby skin to skin during all these checks to comfort them. And then the last thing I want to talk about is moving to postpartum. So everything I talked about is still going to be happening in your labor room. Your labor and delivery nurse will be there. A nurse responsible for your baby will be there. Respiratory therapist will be there. So once you're recovered and we know your bleeding is not an issue and that you have emptied your bladder and you and baby are doing well and all of that, you get transferred over to postpartum, and that's what type of nurse I am. So I will be getting report on you, and I will be reintroducing myself and going through admitting you to the hospital. After you have your baby, you will move from the delivery room to postpartum. This is where I come in. I'm your postpartum nurse. In recovery, I'll help you take care of yourself and your baby. We will work together to help you rest, heal, and learn what to expect as a new parent. Here's what usually happens. I'll come in and say, hi, my name is April. I'm taking care of you today. I am going to check your uterus and bleeding real quick while you're being transferred to me. I'm going to get a set of vital signs. And then I will say, I'm going to go get reports from the nurse just taking care of you. I will be back in a few minutes. Then I will go get a full report on you and come in and go over any questions and concerns and orient you to the room. I will be checking your bleeding, your blood pressure very often. I will be helping you get up and go to the bathroom. I will be checking your baby's vital signs as well as making sure that you are feeding every 3 hours. I will help you manage your pain and answer any questions. So things that can go wrong. It's very normal that once you come to us, you guys have kind of like a adrenaline come down, a lot of crying, a lot of emotion, no particular reason, a lot of hormones going on, but it's just like a big letdown. So just don't be embarrassed. Know that we don't think you're crying because you're sad. It's just a very overwhelming experience. Your cramping and bleeding can be stronger than you expected. Like I said, we will keep track of your bleeding. We will let you know if we're getting concerned or whatnot. And then cramping. This is totally normal, especially when you're breastfeeding. When the baby is sucking on your breast, it is actually releasing a hormone that shrinks down your uterus. So as you're breastfeeding, you can all of a sudden start feeling cramping. That's where it gets mostly intense, when your baby's actually sucking. Let's see. And then if there's any issues, like your baby showing signs of any issues on like their heart rate or their temperature control, we might take the baby from you and put it in the nursery to give it a little longer time to, we call it transition, and then we will hand them back. Sometimes a baby temperature needs to be regulated within the first couple hours. We will let you know if that happens. And then how to prepare yourself. Basically, ask all the questions you want. No questions embarrassing. I mean, if you thought of it, I've heard it. I just had a dad asking me why we haven't given his baby any water. They've been over there over 24 hours, and we keep filling the mom's water, but have never offered to give the baby water. We don't give babies water. They can't drink water. So that might be like, oh, duh. But, sometimes things just go over your head. You are so exhausted. This is why I'm passionate about what I'm doing. You guys, I can talk to you your ear off in the first day you're there. You probably won't even remember my name, what I look like. You guys are exhausted. Some of you have been up longer than 24 hours. You're on pain medication. Preparing yourself for what to expect while in the hospital now is going to be so beneficial to you and your baby. You will be able to relax. You will be able to bond. You'll be able to share this moment with your family, your other children, and not stressing about what's going on. So I hope this helps.